It is a very, very nice chance to have again this meeting for the upper cervical spine injuries. Upper cervical spine, actually, it is different and or differentiated and specialized part of the vertebral column. It is an intermediary part between the skull and the rest of the vertebral column. It's formed by the base of the skull, the C1 and C2, and actually the disc between C2 and C3. We will discuss it in the anatomy, radiology, and the common injuries and management issues. The epidemiology of the upper cervical spine injuries, the main causative injury is the motor vehicle collision in 42%, falls about 20%. The gender is the male more than female by 80% to 20%. Anatomy of the upper cervical spine, as we said, it is a specialized part of the vertebral column that transmits the movement to the, it carries the head. It is about to say it is a ball joint making the head with the eyes looking around with a range of motion from right to left, left to right, about 180 degrees, and flexion, extension, and rotation, and different directions of the movement. It supports the large cranial mass with a large range of motion and unique, so it needs a unique osteological characteristics. The C1 is which is the Atlas. As we remember, the Atlas is a Greek hero or a symbol. They say that it carries the ball or the earth or the cosmos, I think. It has no body. It's only having an anterior arch, posterior arch, and two lateral masses. As we see here, the odontoid, this is the C2 anatomy. This is the C1 anatomy. There is no body, as the body of C1 is incarcerated as the dens or the odontoid process. It has two articular surfaces, superior and inferior articular surfaces. The superior articular surface articulates with the condyles of the occiput with a range of motion in flexion and left and side tilting of the skull, with but a little rotation or minimal or maybe non-rotation. With the movement around, it articulates with the C2, it moves around the odontoid process. Okay, with the joints between the C1 and C2, the inferior articular surface with the superior articular surface of the axis, and articulates the odontoid with the anterior arch of the atlas in a synovial joint with the transverse ligament. The two with the C2, the articular surfaces are widely apart between each other, leaving the pars interarticularis which is vulnerable to fracture. They are connected with different ligaments. As we see here, there is here is the occiput above the base of the skull, then C1 and then C2. This is the upper view is from inside, the posterior from inside, okay, with the alar ligaments and the transverse ligament, as we see in the middle, apical ligament from the tip of the odontoid process, and the alar ligaments from the sides of the odontoid process to the sides of the foramen magnum. Also there's the capsule of the occipital condyles, occipito-atlantal articulation, and the capsule of the atlantoaxial articulation. As we see here, this is the superior facets of the of C1 with a cut section in the odontoid, showing the transverse ligament, anterior and posterior synovial bursae between the transverse ligament and the odontoid, and the posterior articular surface of the anterior ring of the atlas. Another important structure of utmost importance in the upper cervical spine and also in the subaxial spine is the vertebral artery, which passes through the foramen transversarium of C6, 5, 4, 3, 2, and then it has a tortuous path from the foramen transversarium of the axis, and then to the atlas with this tortuosity to allow for rotation of the head and movement, the movement of the head in its wide range of movement. As we see here, this is the tortuous part of the vertebral artery, and we should take care of it with any methods of fixation, either in the atlas or in the axis. Radiographic evaluation of the trauma of the upper cervical spine. We have the plane radiography, the lateral view, and the open mouth view. The lateral view, طبعا الدكتور بهاء يعني أفاض في هذا التوبيك. The lateral view, we have the odontoid, they have the anterior ring of the atlas, posterior ring of the atlas, and the body and facets of the axis, with the soft tissues anteriorly, soft tissue shadow less than 6 millimeters at the level C2 and concave and flat. We have the pre-dense space less than 3 millimeters, and the atlanto-occipital joint congruence. This is a very important part. With the open mouth view, we assess the odontoid, the integrity of the odontoid, and the lateral masses of the lateral masses of C1, with the symmetry at the atlantoaxial articulation. Some radiographic lines which was used in before the era of the CT and the MRI, which was the Harris lines and Wackenheim lines and the Powers ratio, but all are of little importance nowadays. The Harris line, we use the bastion, these points, the bastion, the tip of the odontoid, and the posterior wall of the odontoid. The basio-dental interval to the tip, the basement to the tip of the dents, less than 12%. This is normally more than 12 millimeters. It is more than 12 millimeters. It is abnormal, and it may indicate some sort of subluxation of the atlanto-occipital joint. The basement axial interval, which is from the tip to the of the basement to the line parallel to the posterior wall of the odontoid process. It is from 4 to 12 millimeters. More than 12 millimeters, there is anterior subluxation. If it is less than 4 millimeters, it is posterior subluxation. The powers ratio, which is the ratio between two lines, which are the basement to posterior arch from and the anterior arch of the atlas to the opisthion or posterior tubercle of the foramen magnum. Its importance is not that very important. Okay, but the test or the examination of choice is the CT and the MRI. The CT will show us the craniocervical junction, will show us the occipital condyles and the lateral masses, showing any subluxation, any occipital condylar fractures, or any dense fractures. With the MRI, it shows us a lot of details, where the most important is the condition of the cord, if there is cord edema or contusion or hematomas around the cord, the ligaments, the occipitocervical joints, and the C1, C2 joints also. It shows the spinal cord, the craniocervical ligaments, and the prevertebral soft tissues. Concerning the C1, the fractures or the common injuries of the upper cervical spine, the occipital condylar fractures, occipitocervical dislocation, subluxation, C1 ring injury, odontoid fractures, which is covered very, very nicely and comprehensively with Dr. Professor Fauzi, and the hangman's fracture. We'll pass through these topics thoroughly, inshallah. The occipital condylar fractures. The cause of occipital condylar fractures, actually, it is a vertical compression of the skull, over the cervical spine, leading to the first one, or the type 1 fracture, which is an impaction fracture. It may be unilateral, it may be bilateral, and this depends on the position of the skull during the impact. Type 2, which is an extension of the basilar skull fracture base of the skull, and extends to the supracondylar part of the occiput. And type 3, it is an alar ligament fracture, avulsion fracture of the alar ligament, which connects the side tip of the or the side of the tip of the odontoid to the margin of the foramen magnum. Occipito-atlantal dislocation or dissociation, commonly fatal, and presents about from 6 to 20% of post-mortem studies. 50% missed rate. The patient may be unconscious and may miss this highly dangerous and fatal condition. Usually, the neurological symptoms will be that of injury of the base of the skull or the injury of the lower cranial nerves, and each one, either the hypoglossal, the glossopharyngeal, the vagus, the spinal accessories, each one has its clinical features to be presented if this patient is conscious. There may be also cerebellar ataxia, cruciate paralysis, and cruciate sensory disturbance. Treatment of such conditions immediate, as the Professor Benha told us, that it needs special care with cleaning. It should be put in immediately in a collar. This patient may mostly or maybe mostly will be unconscious. So with the CT or MRI of the brain, you should extend it down to the cervical spine. It should be fixed if there is a doubt, or if it is diagnosed as subluxation of occipitocervical junction. It is attempted to have occipitocervical fixation. C1 injuries, or the ring of fracture, or ring of C1, the atlas. This is first described by Jefferson, 1921, which is characterized by bilateral anterior and posterior arch fractures. This is the typical Jefferson's fracture. It's about 13% of cervical injuries and 25% of the atlantoaxial. Logically, the mechanism of injury is the axial loading, the falling on the head, accompanied with head injuries and other cervical injuries, which can be missed with the head injury in 50% of cases. Neurological injuries are uncommon to have it. We have this classification, either isolated arch fracture or the burst fracture, anterior and posterior arch fractures, or the lateral mass fracture. Actually here, the structure that rules out the stability of that fracture is the transverse ligament. Any fracture or any pattern of this fracture accompanied with ruptured transverse ligament, this is an unstable fracture, and this one should be fixed. Rather than this, we have debate between the conservative and the operative maneuvers, lines of treatment. Lendel's 1988 have classified it related anterior or posterior fractures with the force driving the odontoid through the anterior arch. This is in the plow fracture. It is stable and treated with hard collar, the Philadelphia collar. Type 2, the Jefferson fracture, which is bilateral anterior and posterior arch fracture, where the head and the occipital condyles are wedged in the C1, leading to that type or pattern of fracture with combined anterior and posterior bilateral fractures of the of either the intact and transverse ligament or torn transverse ligament. If it is an intact transverse ligament, so we will pass to the conservative treatment. If there is disruption of the transverse ligament, we will put in a halo vest. They will may have some weeks of traction to reduce the fragments by ligamentaxis, and then fuse the C1, C2 fusion, either the McGurk or the isolated C1-2 fusion. Type 3 is unilateral lateral mass fracture, unilateral lateral mass fracture. It may be accompanied, according to Dickman, may be accompanied by the ruptured transverse ligament or avulsion of the transverse ligament. So if it is stable, it will be treated conservatively with a halo vest. If it is unstable, it will be fixed by C1-2 fusion. Here is the ring of the atlas with that lines of the red lines indicates the Jefferson fracture, as we see, bilateral anterior and posterior ligamentous injury, anterior and posterior ring injuries. The orange line, this is the lateral mass fracture with the odontoid, with the transverse ligament here. With the transverse ligament, either it is in substance tear or avulsion, bony avulsion from its attachment in the medial part of the lateral masses. Here is the mechanism with falling down on the head with different degrees of side tilting of the head, or in the front of the head, the back of the head, and so on. It will lead to the impaction fracture at the of C1. Here are illustrations for the Jefferson fracture and the lateral mass fracture with the transverse ligament tear. Also here there is transverse ligament avulsion and the fracture of the comminuted fracture of the lateral mass. As we said, the atlas fracture treatment, isolated anterior or posterior arch or non-displaced Jefferson fracture, it is treated by a hard collar, Philadelphia collar or halo vest. If displacement more than 7 millimeters, less than 7 millimeters, it's a halo vest. If it is more than 7 millimeters, a halo traction for reduction, followed by C1-2 fusion. If we went to the traction, we will confirm by stability flexion and extension films, but never we do dynamic examination or dynamic films in the stage, in the early stages of the injury. As we see here, this the upper left one. Sorry because the cursor, I don't know if it doesn't move in my machine. The wiring, atlantoaxial wiring and the graft. This is the galley technique. where an iliac graft were put between the spinous processes of C1 and 2, and circulage wire is applied. It is somewhat unstable technique, but with a nice range, a nice rate of healing. The transarticular screw, or the for AtlantoAxial arthrodesis, or the lateral mass fixation between C1 and C2, C2 pars pedicle screw. Odontoid fractures طبعا الدكتور محمد بيه خطاب covered it الحقيقة يعني ايه، وأحاط بها إحاطة جميلة جدا. ننتقل إلى traumatic spondylolisthesis of the axis or the hangman's fracture. الحقيقة اللي هي الكلمة hangman's fracture is a misnomer، لأن هي المفروض إن هي تبقى hanged man fracture, not hangman's fracture. This is the second most common fracture of the axis. The most common fracture of the axis is the fractured odontoid. The second most is that of the traumatic spondylolisthesis of the axis, or this is a fracture of the pars interarticularis of the axis. الميكانيزم هم سموها they told it hangman's fracture because of the mechanism of injury. But the mechanism of injury in the hanging is the submental knot. Put the submental knot and the with falling down of the body of the victim, there will be forced hyperextension of the head, leading to fracture of the pars interarticularis and pulling the head up. So it is distraction, hyperextension injury. In contrary, in the civil injuries, it is not like that. It is distraction, it is compression, hyperextension injury. As we see here, the dashboard injury with the hyperextension of the head and compression of the head. With some sort of shear force, it will affect the morphology of the fracture. It is a younger age group than that of the odontoid nowadays. As we said, due to hyperextension, axial compression, neurological injury is less because actually the canal is decompressed. It is widened by the fracture of the pars interarticularis, and this minimizes the chance of neurological injury. Different types of classification, including that of Levin, 1985, which one of the most famous and practical classifications. Also that of Effendi, which added to the Levin classification, and finally was that of Vaccaro recently. He used the classification, I applied that classification of the A, B, and C. A, bony injury without displacement, and B is the tension band injury, and C is the translation injuries with its practical use and shadow on the lines of treatment. Actually, Levin have classified the types of the spondylolisthesis of the axis into these types. Type A, where there is a fracture of the pars interarticularis with no or minimal displacement, more displacement, and more angulation of the body with type B. And type C, there is more displacement and there is rupture of the disc in between. And type D, there is dislocation of the C2-3 facets. When we look to these types, we see, or we can see that type A, there is only hyperextension with compression, but the disc in between is intact, so it will not displace more. Here, there is hyperextension without forward deflection. When we have another forward deflection, or followed, the hyperextension injury followed by forward deflection, there will be rupture or subluxation of the facet of the C2, C3 disc. With the fourth or the third part, there is complete rupture of the disc from posterior to anterior, and with the fourth type, it is a flexion injury, started with flexion injury leading to dislocation of the facets, and then hyperextension injury that that breaks the pars interarticularis. As we see here, the arrow indicates the direction of the forces. With type A, there is hyperextension. There is hyperextension. With type B, hyperextension followed by forward deflection, leading to rupture of the posterior annulus. With type C, there was severe hyperextension and shear movement leading to the fracture and the avulsion of the anterior annulus. With type 4, as we said, it is a flexion injury leading to dislocation of the facets and then high rebound hyperextension leading to that fracture of the pars interarticularis. With that classification, we will pass to the AO classification. Simply, the simplest part of it is the tension band and the type B, and type C is the translation or the complete ligamentous injury leading to angulation, leading to severe translation of C2 over C1 over C3. The treatment options, as we said, it is either it is stable or unstable. Stability depends on the dislocation or the translation or the amount of angulation of the proximal or of the odontoid. We have either the Helovest and the Philadelphia cervical collar, or the posterior C1, C2, or maybe C3 fusion, or the anterior reduction, grafting, and anterior fixation, plate fixation. So we have these parts, the type 1 and a type 2. Maybe these are treated conservatively, but type 2A and type 3 and type are treated operatively. Here's some examples. We have this is type 1 hangman's fracture, as we see here in this lateral radiograph. There is the fracture is in place with a line of fracture that is it appears as reduced with no angulation, with no translation. This is to be treated with a Philadelphia collar for 8 weeks. Here another type, more than this, it is type, as we see here, it is type 2A. It is treated with traction. As we see here, there is, with the traction, there is increase in the disc space with this traction, so it is an unstable one. So it should be treated with atlantoaxial or subaxial fusion. We see here the technique or the transpedicular, the trans-isthmic screw here, as we see here, down in the left down one. We see here how it is nearby the vertebral artery. So it is actually it is some sort of surgical challenge. Nowadays, it is better to have it with navigation, or with CT guidance, intraoperative CT guidance, to decrease the malpositioning of the screw. Here is the case, one of ours, which was treated with a collar, and then after 2 months, after 8 weeks, it presented with this subluxation, with this spondylolisthesis, and treated with anterior grafting and plating. Another case here, type 3. Okay, type 3. It was treated with with C2-3 fixation and grafting. Another case was treated by grafting and anterior plating. Grafting anterior plating in C1, C2, C3 is challenging because of the cranial, the lower cranial nerves, and because of the angle of the mandible that hinders the fixation of the that hinders the technique of fixation, especially of that of the upper screws. Thank you. طولت عليكم، لكن حاولت ان انا اجري بقدر الامكان to be in that hurry. Thank you all. For questions.
Thank you so much, Professor Ashraf Ismail, for this very interesting talk. شكرا جزيلا أستاذنا الفاضل دكتور أشرف بيه على المحاضرة الأكثر من رائعة دي يا فندم.
ربنا يخليك.
غطيت الدنيا كلها
بروفيسور أشرف.
غطيت الدنيا كلها، وبعدين
طبعا الدكتور أشرف بيه ما متعودين منه على كده.
حتى طبعا فيري ديفيكالت، وفيها ميسنج الانجري ده من حاجات كتير جدا، يعني عشان كده بنقول ان السسبيشس ده، بنقول ان اي ار تي اي او اي عيان انكونشس عنده سيرفايكال انجري انتل بروف اذروايز، وبالذات الابر سيرفايكال بارت ده من الحاجات الخطيره والديستال بارت اللي هو عشان الشولدر والناس اللي رقبتهم قصيره، من الحاجات المهمه قوي ان احنا نخلي بالنا منها.
We have no questions. احنا